This is a video demonstration of ligamentum teres reconstruction using a semitendinosus autograft. This is a case of a 21-year-old male who sustained a direct impact to the knee, resulting in a full-thickness tear of the ligamentum teres. Here we debride the remnant of the ligamentum teres using the flexible electrocautery device in order to allow access to the acetabular fossa. This patient clinically manifested both anterior and posterior instability as a result of his ligamentum teres injury. At this point, we place a guide pin in a transtrochanteric fashion exiting in the area of the fovea. This is done under fluoroscopic guidance. We then ream a tunnel over the guide pin to fit the graft, which we've constructed using a doubled over semitendinosus. We'll debride the intra-articular aperture of the femoral tunnel, and then through that tunnel can further debride the footprint of the ligamentum teres insertion at the base of the acetabular fossa near the transverse acetabular ligament. This view is a view from the anterolateral portal looking directly inferiorly at the transverse acetabular ligament and base of the fossa. Through the femoral tunnel, we can then advance the guide pin into the desired location for the acetabular tunnel. Now, we must take care to avoid the obturator vessels, which lie directly on the other side of the quadrilateral plate and acetabular fossa. There's only about a 5 millimeter bone bridge for reaming of this tunnel, and we'll place the tunnel slightly posteriorly within the base of the acetabular fossa in order to avoid the obturator vessels. Care is taken to avoid plunging in any way, shape, or form so that we ream only through the bone, just enough to create a small bone tunnel that will fit the graft and allow fixation with a cortical button. This is a picture of the graft, and the graft is then introduced after having been prepped on the back table through the femoral tunnel. We're using a knot pusher to push it through the acetabular tunnel, and we'll then use the knot pusher to position the cortical button on the other side of the tunnel in the acetabulum. That fixation can be confirmed under fluoroscopy, where we can visualize fluoroscopically the position of the cortical button and make sure that it is locked against the interior surface of the cortex of the acetabular fossa. So the knot pusher is useful in manipulating the button through both the femoral and acetabular tunnels to make sure it is placed correctly. And then sutures can be used to both manipulate the button and tension the graft. Again, the knot pusher is useful for this particular part. We pull tension on the graft through the femoral tunnel where it is exiting out of the lateral aspect of the greater trochanter. First we tension it in traction, but then release traction, and the femoral fixation is performed with traction off, with the hip in about 10 degrees of hyperextension and about 60 degrees externally rotated. After the fixation has been performed in the femoral tunnel, we then reapply traction, and in this case we've seen the external rotation of the hip caused tensioning of the ligamentum teres. We then repaired the labrum, and finally we'll perform a capsular plication. Now, we must remember that the reason for performing the ligamentum reconstruction was because of instability. This patient sustained a subluxation event which resulted in recurrent subluxations and feelings of instability. The stabilizers of the hip include the capsule, the bony structure, the labrum, and the ligamentum teres. So we'll attempt to address all of the soft tissue stabilizers in this procedure. The last portion of this is the capsular plication, which you're seeing in this particular part of the video. We've used a suture shuttle to pass number 1 vicryl sutures through the femoral and acetabular sides of the capsulotomy, which was created in the beginning of the procedure. These sutures are oriented in such a fashion as to imbricate the capsule and also perform an inferior shift. The inferior shift causes the capsule to come into more tension as the hip is brought into extension. It essentially accentuates the screw home mechanism. This completes our procedure. So we have performed a ligamentum teres reconstruction, followed by a labral repair and a capsular plication. The result in this patient was a stable, painless hip, and this patient was able to return to athletics and a functional, fruitful day-to-day life.